So good afternoon, everyone, and thank you very much for joining us today. My name is Sabrina. I'm a project manager at ECRIN, the European Clinical Research Infrastructure Network, who is hosting this meeting. It is my great pleasure to welcome you to our fourth webinar on the sharing of best practices in complex trials, organized as part of the CoMeCT project. This edition will focus on the crucial topic of patient engagement and involvement in infectious disease research. So the point of this webinar is really to bring patient and the scientific community together to discuss best practices of working together to improve pandemic preparedness research. Today's webinar will feature 4 sessions. The first one will be an introduction to patient engagement and involvement. The second session will be dedicated to strengthening participation through networks, partnerships, and co-design, even in crisis settings. The third one will address patients' perspective, focusing on the long COVID example, and we'll conclude with an interactive Q&A with the audience. Please note that this webinar is recorded, and the recording will be made available on the ECRIN YouTube page afterwards, and slide will be shared with the attendees after the meeting, provided the speakers have agreed to do so. Before we start with the first presentation, I'd like to invite you to take part in a short survey that was designed by our partner NIPH, which gathers stakeholder perspectives on patient engagement in pandemic preparedness. It takes only about 5 minutes to complete. You can access it through the QR code that you can see on the screen right now, or via the link shared in the chat. Without further ado, thank you once again for joining us today. I'm now pleased to hand over to my colleague Lenka Shushkova, who is an ECRIN European correspondent in Czech Republic, and also a UPADI fellow and trainer who will introduce patient engagement and involvement. Lenka, over to you.
Thank you, Sabrina, very much for a nice introduction. And let me share the screen. Are you able to see in the full mode?
Yes.
Perfect, thank you. Good afternoon, dear ladies and gentlemen and dear colleagues. It's absolutely a great pleasure to open to CoMeCT webinar and briefly introduce this very important and very close to my heart topic, patient-public involvement, or in shortly, PPI. My name is Lenka Součková, and together with my colleague Hanna Vlahinková, we serve as a European correspondent for ECRIN in the Czech Republic, and through the strategic partnership between ECRIN and UPATI, we are actively involved in promoting patient-public involvement in a clinical research. In the next few minutes, I will briefly cover why patient-public involvement matters, what patient-public involvement means. We will explain the levels of involvement, and in a few last minutes, I will briefly explain or present some real-life examples from clinical research when the patient-public involvement was applied. But first, let me start with the quote. Who decides what research matters most? It's researcher or patients? I think the answer is absolutely clear. There are patients as a users, as a final users of the results of the research. And that's why patient-public involvement matters. Let me share a simple but powerful quote. I don't want to be just a subject in research. I want to be a partner in decisions that affect my life. It's I said quote, but I would say it is the standard or very frequent usual thing or a thought of patients participating in clinical trial. And this sentence captures the essence of patient-public involvement. Thanks to the meaningful patient involvement, we can achieve research that is more relevant, higher in quality, and more trustworthy. If we are talking about patient-public involvement in research, it is defined as a research conducted with or by patient, carers, and the public, rather than through, about, or for them. It involves an active partnership where people with lived experience help to shape the planning, design, and management of the research. There are many or different levels of involvement. And if we are talking about the participation, it's not public patient involvement. It means, in case of the participation, that the patient takes part as a study subject, newly participants. They only follow predefined protocols, and they have no opportunity to influence the study design or anything else. Then we can talk about engagement. And engagement means providing information on raising awareness about the clinical research and clinical research results, but it's mostly one-way communication. What we would like to see, it's involvement. It means active partnership, two-way collaboration, and two-way communication. And thanks to involvement, patients help shape the research. This is the difference between informed and being involved. These terms are often confused, but only involvement means patient truly shaping the research. I would say that not all projects need full co-creation, but some levels is always beneficial. And what makes patient-public involvement meaningful? Patient-public becomes meaningful when we value the patient's experience as expertise. And we define clear roles and expectation in the beginning of our collaboration. Absolutely, we ensure feedback and transparency, and it's only possible if we have educated persons on both sides. It means that we provide training and support not only for patient and public, but as well for the researcher, how to deal with the patient as a partners. And here you can see the European initiatives and infrastructure who are playing the key role in patient-public involvement. And it's ECRIN supporting the integration of public patient involvement in multinational clinical trials, creating the patient-public working group, and promotes standard and best practices. And HUPATI empowers patient with knowledge on medicine and RD. As I said, thanks to the strategic partnership, we can help each other, and especially together, we can create an ecosystem where meaningful patient-public involvement can happen. So it means trained patient, supportive system, and true partnership. At the last minutes, let me share with you some real examples of PPI. First is about PROTECT study. It was about shaping antimicrobial stewardship trial design, and patients, parents, and different groups were involved in protocol development workshops, many workshops, and they helped assess feasibility of the study in real-world emergency setting, acceptability of deferred e-consent models, and the result, the outcome of this patient-public involvement was that the study design was improved and increased the acceptability for the participants. So here we can see the critical point, how to make protocol more realistic and patient-centered. It's the new shape and new trend what we are observing, that patient voice matters, and through the or from the product-centered research, we are moving to the patient-centered research. The last example is introduction when patient public involvement was applied in infection research design, in tuberculosis. Again, patient public involvement was involved to protocol design, recruitment strategies, and outcome relevant. And thanks to that, the adherence, not only the recruitment rate, but as well to stay in the study at the end was increased and was critical. So thanks to that, it was reflected the real patient pathway. And I would say at the end of this, in the introduction, that patient public involvement is not an add-on the research. It is quality criteria of modern research. And if we take seriously, it's not optional, it's essential. And it becomes much easier when it's done in collaboration with experienced partner, for instance, as ECRIN. So thank you for attention and enjoy the last or the rest of the webinar. Thank you.
Thank you very much, Lenka, for this very comprehensive introduction. So we will keep all questions for the Q&A at the end of the webinar. Please feel free to use the chat or the Q&A session to write your questions. We'll be now moving on to the second section, which is presented by Professor Mahendra Patel, who is the director of the Center for Research Equity at the University of Oxford in the United Kingdom. Mahendra, over to you.
Thank you very much. Thank you. I was just looking at the slides. Apologies, I'm not sharing my own slides, so I'll be having to ask to share. Thank you for this opportunity, and what a great presentation to build on, really. So what I would like to do is share some of the reflections from our work around participation in clinical trials. But one thing I'd like to share with you is let's first focus on when we were before. Three things is: where were we before COVID? What learning has COVID brought us? And where are we now after COVID? And perhaps we might just want to focus on those three things. Next slide, please. But it is more around the partnership working, networks, the co-designing, strengthening those partnerships, even in the crisis setting that we've seen so far. And we can see, despite the advances in health and care inequalities remain one of the biggest challenges in the UK, but also in Europe as well. And too often research doesn't reflect the communities we are meaning to serve, which means solutions are not always relevant or effective. And of course, the centre, since we've established that, is helping to change that to embed inclusivity at the heart of research. Next slide, please. And I'm going to go through these slides very quickly because it is just showing the picture. And if you can just imagine where you are, pre-COVID, we continue to share evidence of decades of health and care inequalities through various government changes. And we know that health inequalities are not new. But COVID brought them into sharp focus. It exposed those deep structural inequities in access, outcomes, and trust. Next slide, please. When it comes to representation in clinical trials, there's a lack of representation, we know, of women in clinical trials. Health experts are calling for more trials to focus on finding new treatments for women, as concerning data clearly shows that they are severely underrepresented, with 67% more male-only studies than females. Next slide, please. And this is just giving you a slight picture. This is children and young people research in the Lancet that showed that it is time to address that inclusivity and the ethnic component for children and young people in research as well, with a clear call to action to increase that and improve that so that we are more representative. Next slide, please. And the clear challenge is there are many reasons for this. It's lack of trust, access, historical exclusion, structural barriers, language, beliefs, behaviors, and attitudes. And importantly, that language we use matters. Instead of saying hard to reach, we've now shifted to underrepresented or underserved, because the issue is not the communities, it's more the system. Next slide, please. COVID clearly brought a light to this, and it was a turning point. National trials needed rapid recruitment at scale, This is what we had when we had COVID, and there was a real risk that existing inequalities would even widen further. But there was an opportunity here to redesign how we engage with communities and to do so inclusively. And that's what we exactly set out to do through partnership working, utilizing networks and co-designing even during a crisis in the pandemic. Next slide, please. This was the innovative inclusive strategy that we developed during COVID for the clinical trials, for the principle where we started off with. And this was a network, really, and this was the partnership that we can show. UK using community pharmacy, the soldiers on the ground, to reach out to those very hearts of the communities often disproportionately affected. Using faith-based organizations, place of worship, and the influence that it could have. And what about university settings, particularly those in areas of high deprivation, and how can we mobilize them? And using media, television, radio, print, social media to raise the awareness and extend our reach as widely as possible. And of course, then the primary care healthcare professionals and health service organisations across the UK to extend that reach further. Next slide, please. And it's beyond numbers, really. Some of the most powerful indicators of success come through stories. Communities began to shape how research was designed. Local champions played a crucial role in influencing uptake. And we saw a real shift in mindset from viewing communities as hard to reach to recognizing that systems needed to change. And these stories bring the data to life. Next slide, please. These are just examples of how community pharmacy, we used the different community pharmacy chains, Lloyd's, Boots, Superdrug, Well, across the UK, and it became news of how they helped to share and spread the awareness of the clinical trials, the importance of participating. Next slide, please. Social media influences are clear that some might recognize Mr. Motivator there, so that we can actually engage those very disproportionately affected populations as well. And then the social media influence on the right-hand side, who use Instagram with nearly 10,000 followers, and the interview that we had 10,000, has 1 million followers, and the interview that we had produced 10,000 hits just alone on that. So this is the power of influencers, really. Next slide, please. Places of worship. You can see here that having places of worship, this is the BAPS Hindu temple in London, which is Europe's most influential Hindu temple. They presented something for us to share this, the information about the slides. You can see on the graph there that the number of people visiting accessing the website increased threefold just by one bulletin that they'd made, and that became global news as well with their partnership as so it just shows. And this was presented at the United Nations as part of our strategy. Next slide, please. University students, as I've mentioned, this is co-designing. They produce hoodies, pop-up stands going in places of high footfall, and that became a key example, and did translations in different languages as well, really, and how we can reach out to those communities as part of outreach work. Next slide, please. Inclusion, diversity. We had our strategy published in the Lancet, which shows that we were able to recruit favorably for people from ethnic minority backgrounds, particularly South Asian diaspora, over and above national census data, and that strategy was produced in the Lancet, as I've said. Next slide, please. So what does progress look like? We saw increased participation from communities that previously underrepresented. We saw improved trust. People were more willing to engage. Recruitment became faster. And importantly, the partnerships we built have contributed to support them. The next trial that I'll move on to. And this is a key marker of success and sustainability. Next slide, please. This was Panoramic, the largest primary care trial in the world in terms of 25,000 patients, participants recruited, and in 4.5 months, the speed at which we did that. And the learning was brought into this trial as well, really. Next slide, please. This is Wales. We can see that we can get into coastal rural areas as well, where traditionally we don't normally recruit. And this contributes to over 6% of all recruits, despite Wales only having 5.2 of the UK population. Next slide, please. Our work has been recognised with the team for the Principal and Panoramic with the Prix Gallienne Award, considered to be equivalent to the Nobel Prize in Biomedical Research. Next slide, please. This led to the Centre for Research Equity being built, which is where we are now after COVID, and where that brings us to moving forward at the University of Oxford. Next slide, please. And it brings together local leadership and national expertise, a combination that gives Europe the chance not to just to set an example, but to influence practice right across the nation, not just in UK as well, as we're working across Europe now as well. At the core of this, it's about weaving equity into everyday practice, making sure our studies are representative, impactful, and reflect the communities we serve. Next slide, please. Some of the landmark partnerships that we've now continued to move on from through the Centre for Research Equity, including with government agencies. Next slide, please. This is Health and Care Research Wales, where we've developed a new 3-year inclusivity action plan advancing research equity in Wales, and was launched at the the Senate offices in government buildings in Wales. Next slide, please. Developing manifestos. This is in Northern Ireland with Health and Care Research Wales and supported by the Department of Health there, that was launched at Stormont at the government estate there as well. Bringing in diverse communities, organisations, everybody partnering together and working around how we can best support inclusive research and engagement. And how we've linked up with, next slide please, and how we now link up with third sector organisations. This was Diabetes UK, moving forward as well, really. Next slide, please. And how we've now formed a national partnership with the Pharmacy Association, National Pharmacy Association, with over 6,000 community pharmacists as its members in supporting clinical trials in the community, and that became news as well. Next slide, please. But it's also important about the researchers, and they must reflect the participants as well, so that there's a safe platform so that people can feel more comfortable in engaging. And this is the NIHR supported incubator work that we're doing around race equity and diversity in careers, bringing more, building capacity for people from Black and ethnic minority origin, and supporting career progression. So just reflect, pre-COVID, during COVID, post-COVID, and most of this work has been done remotely without even leaving our offices. So closing remarks, what does success comprise? Inclusion is designed from the start, not as an add-on at the end. When communities are true partners and not just participants, and when the data we collect actually reflects the population we serve, and perhaps most importantly, when trust is sustained long after the project ends. Thank you very much.
Thank you very much, Mahendra. This was a very insightful presentation. We're going to move right now to the third session that will be presented by two patients' representatives together. So Karina Morsch-Tornstein and Dr. Pauline Oosterijk. So Karina is the chairman of the Norwegian COVID Association next to her professional duties as project manager and change manager. And Pauline is both the president and co-founder of Après-Givant COVID Long France and a researcher by training. Karina and Pauline, the floor is yours.
Hi. And I'm so glad that we can present this. So I'd like to present my colleague Pauline as well here. And I am going to tell you a little bit about the work we do in the Norwegian COVID Association. Can you go to the next slide, please?
Yes. Does it work? Perfect.
So the Norwegian COVID Association was founded in 2022. And it's all run by volunteers, including me. So some of us are patients and some of us are relatives. And it really represents anyone who've had long-term effects from a COVID-19 in Norway. We have around 1,500 members and a little bit more followers on CoMeCT. And the next slide, please. So our aims and what we're working for is definitely more knowledge. We'd like to give more knowledge to healthcare professionals, politicians, decision makers. They need to understand what long COVID actually is, and that there are many, many sufferers in our country. And it's an illness which is not really very recognized, and we don't even have a diagnosis in Norway for long COVID. Only those who end up in hospital can get a long COVID diagnosis, but most patients don't. So we don't even actually know how many patients there are, but we know from statistics that there should be a lot more than what the media say, or even that some patients don't even know that they're suffering from long COVID. We also work very hard to support and to give relevant and useful information to our patients and to their relatives. We also engage with clinical research, and we want to participate in creating more and better clinical research, and particularly for diagnostics, but also for treatment, which will benefit the patients. We also fight for a more equitable healthcare system. We feel that since long COVID is a disease that's not really recognized in some quarters, we feel that it's very important that people can go to the doctors and get help. And we feel that a lot of patients are gaslighted and are not believed. And that's why we also have that on the agenda. And of course, we also want our association to be to have a sustainable engagement. So we work with volunteers and others, and we hope to work for more. Thank you. So I was going to tell you about one case, and Nina, who is also here, works with the same register. So I hope she'll agree with what I'm telling. And Nina, you can step in if you think I'm saying something wrong. So I think a lot of the northern countries are known for their registries because a lot of the northern countries have a lot of good registries. So a medical registry in my country is basically a structured, legally regulated system which collects, stores, and uses health information to improve healthcare quality, and support research, and strengthen national health management. And so for this registry, which is about fatigue without known cause. So ME/CFS, for instance, or long COVID, all have some of the same symptoms, and fatigue is one of those. So this registry is really those patients with referrals, so those who end up in a hospital. And all children are being referred for this, but not all adults. In fact, most adults are followed up by their GPs and do not end up having a referral. And the entry to the registry is actually happening before you have a diagnosis. So you have a referral, you have an appointment to go to see a specialist, and you get sent the link to register information about your illness, your symptoms. And the aim of this is to improve the quality of the assessment and the treatment of the patients with persistent fatigue, and to reduce unnecessary variation in clinical practices across the regions. So the aim is to actually offer a better service to the patients. And of course, also some of the data can be used for research. So the question is, patient participation, yes or no? So I was called in to be a patient voice in this. But actually, those of us who came in, so not only me as representing long COVID, but also ME/CFS, and the parents of children with ME/CFS were also represented, and another organization called Recovery Norway. But we were called in after the drafts of the statutes were written, and also after the questionnaires were actually already in place. And the result was that one patient organization refused to continue and actually left they said, well, we're going to withdraw. We don't agree with this. And we did have to revise a lot of the questionnaires. We did manage to have some more pointed questions on PEM. That was very important, especially for the ME/CFS associations. It's also important for those patients of long COVID who actually have PEM. Not all patients of long COVID have, but for those of them who do. And we also wanted to have, so the questionnaire is based on the PAUL questionnaire, but we wanted to have some that were more about assessment of function. And in Norway, we have something called the FUNCAP questionnaire, which is actually co-created between healthcare and the patients of ME/CFS. So we managed to include this for the patients that were adults, not children. Because children, the FUNCAP questionnaire is not actually legal for children yet. And then we also wanted to add, and that's probably me with my project manager background, but I always think that you should assess whatever you test and you try. So we also included a round of assessing the questionnaire after as a trial, so that we know that the questionnaire actually reaches what it's supposed to do, and whether the patients feel that there are too many questions, whether the questions actually represent the patient's experiences, etc., etc. And then we had to revise all the statutes as well. So we spent a lot of time doing this. And when I was asked to join in, I was told that, oh, this is something where you'll have about 4 meetings a year. But actually in 2025, I think we had about 11, because we had to do all of this work again, since it wasn't done to begin with. And now I'm going to let my colleague Pauline take over.
Thank you very much, Karina. So I'm going to give you a snapshot of what we do in France about long COVID in research. So it's been 5 years now that our association after day 20 is created. We created the association to support, inform, and build together, both with patients, but also with organizations, researchers, clinicians. We have over 800 members, 35 key followers, and more than 50 volunteers. We are supported by a scientific advisory board, and we work both with French and international organizations. And as Karina says, we also have 4 main pillars for our actions. So recognitions of long COVID, healthcare, so supporting patients' rights in development of care, communications for general public, professionals and medias, and research, which is the aim of this webinar. So how do we involve patients, both in research but also in scientific articles? So just the first snapshot on what we can do as patients and association, apart from doing research project like a clinical trial. So we can represent patient needs in boards of institutions such as the research in ANRS. We can be involved in conferences to review abstracts or present posters or conferences. And we also do a scientific watch that you can find freely on our website. And we have more than 8,800 articles. And now to go more into the research project, as Lenka just said, we've tried to summarize our commitment into numbers and into level of involvement. So since 6 years, so since 2020, we have summarized what we've been involved to show how much we've been doing as patients. And we've been involved in 83 research projects or grants that has either contacted association or that we have contacted to work with them. And for doing a research publication, we've tried to summarize and describe the type of involvement we've been doing with them. And we've used the same level of involvement that Lenka has just presented before, that is really published in the literature. So we had a few projects where we didn't participate. Either we refused the participation because it was too late, or because it was not ethical, or because it didn't respond to patient needs, or the participation was just not formalized at all. We had a few projects, so 5% of the project where we were just informed, so we recruit the patients or we were just informed of the study. We had 15 projects where we were involved as consultants, so to collect feedback or proofread documents. We had also a project where we were involved in some parts of the research project, so work on questionnaires or recruitment. But most of our projects were as partners, so which means we were real meaningful partner at all the steps of the project and also in the governance. And we had a few projects where we had the chance to be the lead or the co-lead. So the impulse really came from the patients and of course with the scientific support. So as Lenka said, you can see there's a diversity of involvement, and what matters the most is to be transparent on what patients do. So to give you an example, a real example of what a successful partnership means, I will give you an example of the Long COVID Companion app that we developed from a tweet to the real development of a real app with the Luxembourg Institute of Health. So it all began in 2022. I got a tweet from a researcher, Guy Fagarazzi, who invited us to review one of his papers on long COVID. I didn't know him, he didn't know me, but we both were on Twitter and commenting on long COVID, and he saw our association and our work on research, and he basically just invited us, and that was the beginning of a really meaningful partnership. So first we just did consultation, but then this evolved to a real partnership where we were truly involved in both the design but also the evaluation, as Karina said, of a PhD on long COVID made by Aurélie Fischer. And that led to the co-development of a translational research project, which led to the app, the COVID Long Companion app. So that's based on a true story. And to give you just a bit more features on what we do with the app. So the app is created to respond to patient needs on the fluctuation of symptoms. So how do we present to doctors and GPs the fluctuation of our symptoms along the years? So the app monitors the symptoms, you have a voice diary, you have a calendar, you have charts. And based on patients' feedback, we also created modules like Coherence Cardiac, or we also added connection with other apps like Google app, Google Health app. And now the app also enables research studies. So we really aim for the app to be used by clinicians to help during clinical trials. And the first study we are doing is to identify vocal biomarkers of long COVID. So the study is still open, and please feel free to participate and download the app, and also ask us for more questions. So now I'm gonna share the slides with Karina, and we are gonna both talk about key messages, some of which have already been told by Mahendra and Lenka, about how to do PPI meaningfully. The first thing, which has been repeated, but I think will never be repeated enough, is contact us early. Again, last week we had a researcher contacted us for huge grant for the European Union, but they contact us 1 day or 2 days before the deadline. That doesn't enable us to read the full protocol, understand our role, trust the collaboration. Like, it's just stressful for the patients. I think if it was a researcher, it would be the same when you called 1 day before the deadline. So yeah, I think, and we all think that if we spend the time to do it before, it helps. We know it's difficult to contact associations because you need to know them in advance. And that's why you have ECRIN, you have networks like us that helps researchers to find the good patients for their project.
So, and I was going to talk about the next point, which is plan the PPI meetings in advance. Yes, if you want to have patients with you, please do organize a meeting, have a proper agenda, and not least, do make minutes after the meeting, because long COVID patients, some of them really struggle with cognitive issues and may not remember everything. And it also allows them to prepare themselves for the next meeting. So if you have a good agenda and also have minutes, then they could come in and actually do a proper job because they are well prepared.
Next, it's also very important to track project outcomes and give feedback during the project, but also when the project is done. On the 83 project we've done, like half of them might have not give us feedback at the end of the project, so we don't know the results, we don't know the follow-up, so we had to come back to them and say, hi, can you tell us how the study went? Do you have publications? Do you want to do communications together? So this is really important during, to show what is the role of the partners, what do they do together, but also after the project is done.
And then it's really useful to have a dedicated project manager for the PPI who is there to administrate and organize the work that the PPI are going to do. And that will be very useful because sometimes it's the patient organization sit and have to do a lot of the administrative work. So give a person responsibility and actually pay that person would be really useful.
Exactly. And that leads us to co-developing the clear engagement framework. So it means that when you do PPI, you can follow methods. There are several types of theoretical framework to do that. So just choose one that is well with your study, and then it will help you to understand the role. So who does what, when, why, how do you compensate scientifically, but also financially, the people who are spending time of their energy to doing the research? And also something that is often forgotten, say, how do you communicate with the patients, the association? Which channel? Like, is it phone? Is it mail? Is it something else? And how do you comment on the document? So communication is something that is always forgotten.
And then, of course, it's really quite useful if everybody agrees on what is the role of the patient in this work. So it's useful for the patient because then the patient can do a better job, but it's also useful for the researchers that they are clear about what they expect. So actually sharing what are the values, what is your role, what are you going to commit to is really important. And also it gives us the opportunity to train so that we can be good patients and participate in a good way for the research.
Last but not least, evaluate PPI. So what works well, what didn't work well in terms of process, in terms of outcomes, and also really specify what was done differently because you had patients and that you have not done if they were not there in the project. And again, as for the framework, you have lots of theoretical frameworks to do it. So just choose one. You have patient-led scorecards, you have PPET. So there are different ways to do it, but it's really important to plan it from the beginning to be sure you do it well at the end. So yeah, that was our key messages, and we are happy to discuss it more if we have time at the end.
Thank you very much, Pauline and Karina, for this really great presentation and for sharing your perspective with us. So we're now moving to the Q&A session, which will be moderated by Professor Nina Langlin. So Nina is actually the coordinator of the CoMeCT project that is organizing this webinar. She's a medical doctor specialized in infectious diseases at the University of Bergen in Norway. So Nina, the floor is yours.
Thank you. And I must say, I enjoyed tremendously these different perspectives I've heard today, both Mahendra and how you've worked in the UK to get community engagement, how to get the minorities involved. Very impressive. And then Lenka talking about PPI. How and in design. And I want to dwell a bit with that because I am an example of somebody who didn't contact the patient organization, not even the day before. I'm participating in an EU proposal, Karina, and I know you well, so I should have. And then you end up thinking, should I contact her now or if we get the grant? You know, this is how scientists sit thinking. And we have set aside funding for a patient organization, and it's not finalized in any way how to do it. But I'm just the best example of wishing the best, wanting the best. But then in the end, you know, big partnerships, and you really don't know how to deal with it. To Lenka, I must say, you talked about one specific thing about emergency settings. And I'm chair of the ethics committee in my region of Norway. And as an ethics committee, we actually do request in these cases where there is inclusion in emergency settings to include patient organizations before we approve these projects. I do see in the chat, Pilar, you have a comment, quite a long one from cancer research. This is an open call for initiatives in cancer research. Fund projects that enhance patient and citizen participation, promote ethical and responsible use of health data, foster inclusive and scalable solutions, and strengthen collaboration between research, healthcare, and society. You know, this could be something also in infectious diseases research, certainly. I leave it maybe to the panel for their impressions of the other presentations. It's really interesting to hear the different perspectives, and I was wondering when this is to Lenka, when involved in at the design stage, because that's a difficult when you, for instance, design a placebo-controlled intervention. My experience is that patient organizations sometimes wish all to get some level of the intervention may be delayed or in other ways. So that's an interesting topic. But now I see Pauline has a hand raised, and after that, Mahendra.
Yeah, thank you very much. I'm thinking, so we all shared that it's better to involve patients or associations or citizens before we do a project, but that has practical implications. So how do you involve people that you don't know before you begin a project, before you get funded? So it's not always feasible or practical. So as an association, what we do is we create a network. So we try to be known by researchers. We try to connect with researchers. So when they do a project, they call us before they do the project. So that works as that for us as an association side. If I take my researcher hat, what I know works well is to create PPI resource group that are in-house. So in-house of a network or in-house of a project that you know about, or in a department or in a clinics. So for example, in our research network that is called CoMeCT, we do have an in-house PPI group called CoPrica. So each time a researcher wants to do a project, they call this group before we do the project to involve them before. But if you don't have that, I was wondering, maybe asking a question to ECRIN. So how can ECRIN, for example, help find patients or associations to go in the ground before the ground begins? Is ECRIN able to do that? Or that was a question I had about PPI in advance.
Thank you. That would be my question too. Sabrina, could I or anyone else just contact ECRIN?
Well, you can. And what we do, if I'm not mistaken, because I'm not directly involved in that, is we actually work with UPatty, and they have a sort of a matchmaking tool, which is called the UPatty Connect tool, where if we have a description of your project, what it is that you're looking for, they can match you with a patient representatives that would fulfill the roles that you would like them to endorse.
Just before I leave the word to Mahendra, I see in the chat you are saying possible ways to raise awareness among patients, include them. Maybe ECRIN or others like Mahendra and the system in the UK could be such a contact point. This is a very interesting question. Mahendra, please.
Thank you very much, Nina. I think just to say, before I answer the chat, if I may, is that it is about building trust. I think we have to look at the historic patterns. Of course, we've had a short presentation, and thank you, everyone. It's been very informative. But the historic decades of inequalities and where we've put money into addressing inequalities, and how after COVID, without any significant investment, what we showed at scale, at pace, through the Centre for Research Equity and the trials for Principal and Panoramic, where across the 4 nations we were recruiting over and above national census data to those very audiences that were disproportionately affected, historically not engaging in research, and this was without any investment to them. I think so that, and I think the language is important. I think one size fits all doesn't cut it. We have to look at the different communities and the different people that we have, and how we building that trust is the key part. People from Black ethnic minority have traditionally been low in engaging into clinical research, yet we managed to pull and partnership with the Nigerian diaspora, which is the largest Black community in the UK, really, and who said we want to engage in research. So I think a one size fits all doesn't work. We have to tailor this to different communities. We have to understand those different communities, and we need to build those trusts, which is a lot ongoing process. Just in answer to that, to the question from Shoaib, thank you, sir, is the possible ways to raise awareness among patients and public, especially ones who may not be aware of ongoing, and this is ongoing research. This is where we widen the inequalities, really. And I think this is where we need to engage with those community groups, the faith groups, the community leaders, and build those trusts, build new relationships, strengthen the relations that we've already got, but also for them to feel that the researchers actually reflect the community, the diverse communities that are participating, so that it doesn't become a disconnect and there's that element of trust as well. But happy to share the strategy and build on that strategy from a Europe-wide perspective. I think there's lots of potential here as well.
Thank you, thank you. And I expect Pauline and Karina see the question from Victoria, my co-chair of CoMeCT. One of you, Karina, maybe, Pauline. One of you need to get your mic off.
I think Pauline should answer that one, because she wanted to have a positive example of something that worked. I was going to talk about something else, so I'll leave the word for Pauline.
Thank you, Karina, and please go back if I'm mistaken. So for communications, what I was saying was communications also during the PPI. So how do you communicate with the patients so they know how they can be involved? Because sometimes that is forgotten. But so what are the ways to include patients in the communication around research results, limitations, and policy implications? So to do that, you need to prepare that from the beginning. So being involved from the ground, and in the ground planning money to do it. So planning someone to do the website, to do the deliverables in a way that patients can understand them. So I will say, to reply to your question, I will say planning it, use a budget to do it, and do not restrict PPI to communications. Communications is just the end of the project, which is really important to implement the project, to make sure the project can be transferable and also known by the patients. But what is more important is that the patient's needs are taken into account during the project, if I try to make it quickly.
Thank you. Thanks a lot. Karina, you had another question or a comment to raise.
I had a comment for Mahendra, and I just loved what you presented. I think it's really important. I agree so much that we have so many communities that we don't include in research, including women, including people from all kinds of backgrounds. I think that's wonderful. And I think with the illnesses that me and Pauline represent, we have another issue, which is that our illnesses are usually not recognized and are gaslighted. So we have another way of not including us and not seeing the value of having patients with us. So that's another issue, and that's another way of differentiating us and not including us and not seeing the value.
Thank you. Mahendra, is that related to Karina's comments?
It is, and it's also one of the ways we can bring confidence into participants is not just to include them from the beginning and include them till the end, but it's how are we getting that information and the results to those patients that's meaningful to those participants that have actually helped to contribute towards that evidence. So I think it is important that we look at that in a fashion, in a mode, in a language that is acceptable to them as well, so that they're kept up to date as to what's going on, and that allows them to be involved, to have some ownership and continue that relationship. Thank you.
Thanks a lot. Then to keep within time, I think Pauline will be the last one to comment. But before you do, I see in the chat now that Ekrin has asked for feedback on the webinar, but please also, look at the survey at the top so that everyone who's interested can respond on that. Then, Pauline, your word is the last one.
I will try to make the best from it. So what I think we share between all the speakers was that we don't want to scare anyone with PPI. PPI can have different level of involvement. It's okay if you don't do partnership from scratch from the beginning. As we give you an example from the long COVID companion app, we began by consultation, then we jumped from partnership to co-led. So it's really okay. I see Pilar Caro talking in the chat, not to do partnership and all the time and every steps. What is really important is to be transparent, honest, and tell what you want to do and communicate well. And as soon as you do what you tell and tell what you do, it's okay. So I think that's something that it's a big key messages from our webinar today.
Thanks a lot. Sabrina, will you close this seminar maybe?
Yes, thank you very much, everyone. So first of all, a big thank you to our speakers today who had very insightful presentations. And of course, to the attendees, I wish you all a great day. Thank you very much.